Welcome to the deep dive. Today, we're really plunging into some source material you shared, focusing on, well, a pretty critical area in vascular surgery.
Understanding the risks of mortality associated with open repair of abdominal aortic aneurysms.
Yeah.
AAAs.
Exactly. And the main source we have is this large study.
California patients, right?
Yeah, a big cohort from California who had this specific surgery, the open repair, over several years. This is back in 1995 to 1999.
Okay. So our mission really is to unpack what this study tells us,
Right.
especially how outcomes look different depending on patient age, and pull out the key insights. And, there's a finding we'll get to that's maybe a little surprising about when the risk of mortality is actually highest. It's not just right after the surgery.
That's a key point, definitely. Okay, so maybe let's just set the stage first. What exactly is AAA repair? Why focus a big study on it?
Well, simply put, an abdominal aortic aneurysm, the AAA, is like a weak spot, a bulge in the body's main artery, the aorta, down in the abdomen.
If it
ruptures, it's usually catastrophic, life-threatening. So the whole goal of the repair surgery is to fix that bulge before it can rupture, to, prevent that emergency and extend the patient's life.
And this specific study, it focused on open repair.
That's really key, yes. Because during the study period, the late 90s, open surgery was, it was the standard way to do it. It's a major operation.
Right. Things are different now.
Very different now. Endovascular repair, EVO, is much more common, less invasive. But looking back at this large group who had open repair, it still gives us really crucial insights, especially about those fundamental risk factors like age. And those factors, they're still relevant today, even with EVO.
Okay, that makes sense. So how did they actually do this study, looking back at, over 12,000 patients?
Yeah, it was a retrospective review. So looking back at existing records, they used the statewide hospital discharge data from California. That's from OSHPD, the state agency.
Okay, the Office of Statewide Health Planning and Development.
Right, and they connected that hospital data to the state death registry.
Ah, so they could see who survived long-term.
Exactly. Not just in the hospital, but, well after discharge. The data covered residents aged 51 up to 100 who had that open AAA repair between 95 and 99.
That's a pretty wide age range.
Yeah.
And 12,000 is a solid number. Did they mention demographics? Anything stand out?
They did. The population was mostly male, about 81%, and predominantly white, around 91%.
So that's something to keep in mind, right, when thinking about how these numbers apply more broadly.
Definitely. The authors pointed that out, too. It's a limitation for generalizability.
Got it. So what exactly were they measuring? What were the outcomes they tracked?
They looked specifically at mortality, death, at 3 different points in time after the surgery.
Which were?
Mortality while still in the hospital, mortality within the first 30 days, that kind of perioperative window, and then mortality out at 365 days, so 1 year.
Okay. Let's get into those findings then. Maybe start with the planned surgeries, the intact AAAs.
Sure. So for those elective intact repairs, the overall mortality rates they found were 3.8% in hospital, then 4% at 30 days.
Okay, pretty close together there. And at 1 year...
365 days, it was 8.5%.
8.5% overall at 1 year. But you said age was the big story here.
This is really the core finding, yeah. The mortality risk goes up significantly, quite dramatically with age.
How dramatically? Can you give us the numbers?
Yeah, look at the 1 year mortality, the 365-day rate. For patients in the 51 to 60 age group, it was only 2.9%. Quite low.
Okay, under 3%.
But then you jump to the older patients.
Wow.
For those aged 81 to 90, that 1 year mortality rate went all the way up to 15%.
Wow, from less than 3% to 15%. Just based on that age bracket, that's a huge difference.
It really is. It just paints a stark picture of how risk escalates as patients get older, undergoing this, very significant operation.
Okay. Now, you mentioned something earlier, that surprising finding about when the risk occurs.
Ah, yes. This is really interesting. What they found was, for most of these patients with the intact AAAs, specifically anyone over 59 years old, the chance of dying after that initial 30-day period, so between day 31 and day 365, that risk was actually higher than the risk during the initial 30 days, the perioperative time.
Huh. That is counterintuitive. You'd think surviving the surgery and the immediate month after is the main hurdle.
Right. You might assume the risk would drop off significantly after that initial recovery, but this data showed, no, there's this substantial ongoing risk throughout that whole first year.
So the danger doesn't just disappear once you're discharged?
Not at all. It really makes you wonder, what's driving that later mortality? What's happening between month 1 and month 12?
That's a key question. Okay, so that covers the planned repairs. What about the emergencies, the ruptured AAAs? I imagine the numbers are much worse.
Oh, orders of magnitude worse, yeah. For ruptured aneurysms, the overall mortality right off the bat in hospital or within 30 days was 45%.
45%?
Almost half, yeah. And at 1 year, 365 days, that climbed to 54%.
Over half didn't make it a year after a rupture repair. Did age play a similar role there? Increasing risk?
It did, yes. The same trend, but starting from that much higher baseline. For the 51 to 60 group with a rupture, 1 year mortality was still high, 35.4%.
Okay.
But for those over 80 who had a rupture repair, over 70% 1 year mortality.
Just devastating, especially for older patients in an emergency setting. Now, age is clearly a massive factor. Did the study point to anything else? Other predictors of mortality?
Well, advancing age itself was an independent predictor across all the time points they looked at, but they also found that a higher Charlson comorbidity index predicted higher mortality.
Right, the Charlson score. That measures other health problems the patient has.
Exactly. It's a way to quantify their overall burden of chronic disease. More comorbidities meant higher risk.
Makes sense. What about the hospital? Did it matter where the surgery happened?
It seemed to, yes. They found that having the surgery at a low-volume hospital was linked to higher mortality rates, both at 30 days and at 1 year.
For both intact and ruptured cases?
For both, yeah. Hospital volume seemed to matter.
Okay, so putting this all together, how did having this kind of detailed, age-specific data change things? How was it valuable?
It was incredibly valuable, particularly for patient counseling. Before studies like this gave such granular detail, a doctor might just quote an overall average risk, like that 8.5% 1 year mortality for intact repair.
Which isn't very helpful if you're 85 versus 55.
Precisely. This study allowed for much more specific, tailored conversations. A doctor could say, okay, based on your age group, the data suggests the risk looks more like this percentage rather than just a broad average. It helps personalize the risk assessment.
That seems crucial for informed consent, especially for a big operation. Were these findings, these mortality rates, in line with other research from that time?
Generally, yes. The rates they reported, especially for the intact open repairs, that 3.8% in hospital, 8.5%, at 1 year, they were quite consistent with other big studies looking at open AAA repair around the same time, like studies using U.S. Medicare data.
So it fit the picture for open repair back then. But like we said, the landscape has shifted dramatically. With EVAR, the endovascular approach, how do these open repair numbers compare to EVAR outcomes?
Well, that's where you see a really big difference. Study after study since then has shown that EVAR generally has significantly lower mortality risk right around the time of the procedure and in the short term.
Lower than open repair?
Yes, quite a bit lower. And that difference is often most pronounced in older patients, say those over 70.
And that difference, I assume, is a huge reason why EVAR took off and became the preferred method for many patients, especially older, potentially higher risk ones.
Absolutely. The less invasive nature combined with better early survival rates, particularly for the elderly or those with more health issues, really made EVAR a game changer.
So when you think about this study's findings, that 15% 1-year mortality for open repair in 81 to 90-year-olds, and you put that next to, say, average U.S. life expectancy being somewhere in the late 70s.
Right, around 78, 79 years currently.
It really highlights just how critical that individual risk discussion is, doesn't it? Especially for an older person thinking about elective open repair. You're weighing the risk of the surgery against the remaining lifespan and quality of life.
Exactly. It becomes a very complex calculation, and having detailed age-specific data like this provides really essential context for making that decision with the patient.
Okay. Now, the source material you shared also had some commentary that looked beyond this specific study's data, mentioning other factors doctors consider now. Frailty came up.
Yes, that's become a much bigger focus in recent years. Assessing a patient's overall frailty, it's not just about counting diseases, but looking at their overall resilience, their vulnerability, their sort of physiologic reserve.
And there are specific tools for that, frailty indices.
The commentary mentioned a couple examples, like the Modified Frailty Index, or MFI, and the Clinical Frailty Score, CFS. These are ways to try and quantify frailty.
And why might these be better, or at least add more, than just looking at comorbidities like the Charlson score?
Well, the idea is that frailty gives a more sort of holistic view of how a patient might handle the stress of major surgery and recovery. These indices might be better at predicting not just death, but other bad outcomes too.
Like complications?
Yeah, complications or morbidity. but also things like losing independence, needing to go to a nursing home or rehab facility instead of going home. They try to capture functional status and resilience, not just diseases on a list.
So trying to get a better handle on who's really likely to have a poor overall outcome, not just survive or not survive.
Exactly. A more nuanced prediction.
The commentary also mentioned things patients could do before surgery, modifiable risks.
Right. Another important angle. There was a review mentioned that found using certain common medications before elective AAA surgery seemed to offer a long-term survival benefit,
Which medications?
specifically statins, beta blockers, and aspirin. The suggestion was that optimizing these beforehand could improve long-term outcomes, not just short-term.
Interesting. And research is still looking into other factors too, like surgical technique, gender, ethnicity, maybe the aneurysm's shape.
Oh, absolutely.
Yeah.
The field is always trying to refine things, understand how all these different elements, patient factors, technical factors, anatomical factors, play into the ultimate outcome after AAA repair.
Okay. Now, no study is perfect. And the authors of this California study and the commentary writers, they pointed out some limitations. What were the key ones for this particular research?
There were several important ones, yeah. The database they use, the OSHPD data, it didn't have information on the actual size of the aneurysm.
Which matter for risk, right?
Definitely matters for rupture risk and complexity. Also, the way they identified cases using diagnosis codes, the ICD codes, might have accidentally included some less complex types of aortic repairs.
Oh, okay.
And critically, as we've discussed, the study only looked at open repair. So its direct relevance to today, where EVAR is so common, is limited.
Right.
Then there's the patient population, mostly white men, which limits how well you can generalize the findings. And a big one. The data only captured mortality. It didn't tell us anything about complications, recovery, quality of life, that sort of thing, only whether patients lived or died.
And why is it important for us and for you listening to keep those limitations in mind?
Well, it just means we need to be careful about interpretation. This study gives us a really valuable snapshot of mortality risks for open repair in a specific group of people during a specific time. But it's not the whole story.
Got it.
It gives us foundational insights, especially about the impact of age, which are still hugely relevant. But we need other research, newer research, to understand the full picture with current techniques like EVAR in more diverse populations and looking beyond just survival.
Okay, that makes sense. So let's try to wrap this up. What are the core takeaways from this deep dive?
I think, number one, this study powerfully confirmed that the risk of dying after open AAA repair goes up substantially, really significantly as patients get older, that age-stratified data is crucial.
Okay. And number two?
Number two is that really interesting finding about timing, that there's a significant period of ongoing mortality risk after the initial 30-day recovery, between month 1 and year 1. Risk doesn't just vanish after discharge.
Right. And having this kind of detailed age-specific data is valuable because
it lets doctors and patients have much more realistic, personalized conversations about risk, moving beyond just general averages to something closer to an individual's potential likelihood of different outcomes based on their age and health.
it helps paint a clearer picture, as you said, for a really tough decision.
Exactly.
Okay, and maybe one final thought for you, the listener, to mull over something directly from the source material. The authors themselves noted that while they found that higher mortality rate between day 31 and day 365, their study couldn't really explain why it was happening.
Right. What exactly is driving those later deaths? Is it late surgical complications, worsening of underlying health conditions, maybe issues with follow-up care, other unrelated events?
We don't really know from this data, and figuring that out, understanding the causes of that continued mortality after the initial post-op phase, that seems like a really important area for more research and clinical focus, doesn't it?
Absolutely. That remains a key question.